Okay. The short answer is yes. So hopefully we'll get into some details that'll be helpful for you guys as you move through the training and into your first couple years of practice. So a lot of this stuff you guys actually know already, that over 20 years ago we had the advent of EVAR, and really this has become a growing technology that has really replaced a lot of open aortic surgery, with over 80% of all aneurysms being actually repaired endovascularly in one method or another. So now we really kind of reserving open repair for a very robust young patient population who you want a very long-term durability for, or those who kind of have a more hostile aortic anatomy. So why is EVAR so prevalent, and why do we like it so much for a lot of our patients? You have a lot of reduced perioperative morbidities and mortalities, right? Lower rates of periop mortality, it's a decreased OR time, very significantly less blood transfusions and blood loss. You have less respiratory complications, cardiac complications, etc. Shorter hospital length of stay. Patients really like it. They get out the next day. So we know it has a nice upfront benefit with mortality and morbidity, but as we look long term, as we're applying this endovascular approach to our aneurysms, how is EVAR faring? And what we can see is when we start to get past 5, 6, 7 years, we can start to see some failures of our EVARs requiring reinterventions, potentially open conversions due to sac growth and different types of endo leaks, which we can see here from the DREAM study. When Dr. Schermerhorn did a Medicare analysis of matching nearly 40,000 EVARs to open repairs, what they could see that in the longer term, you're having a higher rate of ruptures after EVAR compared to open, and that kind of longer failure that we can see with EVAR. And then when we start to look at why are we failing long term, what's going on that's causing our repair not to be quite as durable as an open repair, we can start to look at some of the anatomic factors that contribute to how our EVARs are doing. So Andy Schanzer took a look at the anatomic criteria and wanted to see if being on IFU impacted the outcomes of EVAR. So for those of you that are not exactly sure what IFU is, it's instructions for use. And so this is mandated to be produced by the FDA on all products and drugs, devices, and it gives how-to information, how to use the device, but also the anatomic criteria that is indicated for that device. So this is a little bit of an older study, but what it looked at was different IFUs for a variety of grafts. So we have neck IFUs, and that tends to be your proximal sealing zone, right? So that tends to be the length of your seal zone, the diameter of your seal zone, the anatomy of your seal zone, and the angulation. So that is how well are you going to seal with the graft that you're using. We also have other type of IFU requirements which have to do with our common iliacs with regards to a distal seal zone. This is not necessarily as prevalent now because of the different grafts we have, the iliac branch devices, but then we also have the ability to deliver the device safely. So with regards to the IFU with our external iliac criteria. Nowadays, we can help modify that with intravascular lithotripsy or cracking and paving to kind of overcoming some of these limitations with the IFU. So when they looked at nearly 10,000 EVARs, they saw at the 5-year mark that there was a sac enlargement in 41% of patients. So again, looking out to that 5 years, what's going on? And what they saw was that aneurysm sac progression and enlargement was significantly correlated with being off IFU, even when they kind of liberalized the IFU criteria in the study. So why do we see EVAR failing in the long term? There's a couple reasons. We can have the actual device that's failing, we can have an aortic failure, or we can have kind of a physician failure where we're pushing the IFU into a different patient population it maybe shouldn't be applied to. So device failure. Devices can fracture, devices can migrate. So this is an inherent device failure, not really what we're talking about here. Now there is some definite aortic failure. So people who, when you initially do their aneurysm, maybe the neck's a little bit big, but still is within IFU, they're kind of overall ectatic, and they'll have some more proximal aneurysmal degeneration. And that, there's not a whole lot you can do about that at the moment, but that can be a mode of failure. The physician failure really comes from when we're kind of pushing the IFU limits, particularly with the neck seal zone, and trying to get a seal and decrease pressurization of our sac when we're really not sealing it perfectly in the proximal area. So we have a lot of studies out there that talk about long-term outcomes when it comes to if you're working off of IFU or not. So this is a retrospective study at a single institution that demonstrates that actually only 31% of the EVARs done at that institution was actually on IFU or fit that criteria. But what they noticed was that there was actually no difference in outcomes at around the 3.5 year mark in patients who were on IFU versus off IFU. But what they did note was a lot of the off IFU criteria was actually more due to the iliac anatomy as opposed to proximal landing zone. So what is our landing zone we want? We want nice, healthy, parallel aortic walls. We want it to be free of disease, thrombus, calcification. We don't want a ton of angulation. And in some ideal world, you want greater than 20 millimeters of length. I don't know what world that is, but it's not the one I live in. But really, only about 50% of cases that are being done are actually within an IFU. So what is our suboptimal landing zone? It's our hostile neck that's really contributing to failure of our EVARs long term. So it's a short neck where we're really trying to get a real short seal zone, maybe with some adjunctive measures, a wider neck or a conical neck. And then if you have some disease, circumferential thrombus, some calcification, and then of course larger distal iliacs. However, again, with other kind of technology such as the iliac branch device, coiling and covering, we can kind of address that. So when you look at a meta-analysis that was recently published that looks at EVARs outside of IFU, they took 17 observational studies, and it was nearly 5,000 patients, and it looked at the prevalence of off IFU, and then we noticed that this is definitely increasing over time. So as we get more comfortable with our technology, as our technology kind of pushes that boundary in the neck length, we're actually pushing that as well in who we're placing these grafts in. And when you look at their meta-analysis, you can see freedom from aneurysmal-related mortality and aneurysm-related reinterventions. There's no difference whether you're on IFU or off IFU. And so their conclusion is that standard EVAR outside IFU could be considered in select patients. But what we want to start to actually tease out in these meta-analyses is all off IFU the same, right? Is it an iliac issue versus a proximal neck issue? If you have two or more off IFU, so if you have a reverse conical neck or a short neck with severe angulation, is that going to have more of an effect of your failure compared to just having one off IFU? So when we actually look at neck-related IFU indications, what we can actually see is that when we drill it down to how we're getting our proximal seal, we can see that this is actually making a difference in our failure down the road. So when you look at patients who are outside IFU with regards to neck alone, you have an increased type 1A endoleak of 22% versus 2% at 5 years, and then also a significantly decreased survival rate. So how does this work? This is not a yes or no dichotomy. This is kind of a continuum. We start with like a short neck, then we get juxtarenal, paravisceral, all the way to a thoracoabdominal aneurysm. So how do we do this if we don't want to address these in an open manner? We have different visceral artery incorporations. We have branches. We have fenestrations. And what we can see is when we take our graft up in these more marginal necks, when we take our graft and we're healing in healthy aorta, and we're fenestrating them, what we can see is we have a nice seal, and our rate of type 1A endoleak at a 5-year period is very low. It's 1.5% compared to the 22% we saw in the off IFU in the prior study. So there's a lot of devices coming out, and I'm not going to get into this. This is off topic of what we're talking about, but ultimately there's a lot of devices that are investigational right now, some that are going to become on shelf, that are going to be good access for us, but different types of branches, fenestrations, and combinations in order to help treat patients and really not have to push the boundaries of a typical infrarenal EVAR. So as we know, late EVAR failure is common, and the durability is very much patient-specific, device-specific, but also kind of our judgment and how we're pushing those boundaries, particularly with the proximal neck. It's really important we're trying to find the most suitable landing zone in the healthiest neck. And again, this is in combination with patient factors, right? So we have a ruptured aneurysm in a not very healthy person. You may want to push that as opposed to someone who has a very long overall estimated survival and not a great landing zone. That's someone you may want to consider open or actually doing one of our fenestrated grafts. And as we're kind of seeing with the data, patients who are well outside the IFU probably should be considered for either open repair or fenestrated or branch grafts. Thank you guys very much for your attention.